Hello everyone, I am Dr. Siad, MBBS, MD in Health Informatics. I am also specialized in clinical terminology and medical coding.
In this video, we are going to see ICD-10-CM General Coding Guidelines. We are going to learn following 19 topics of General Coding Guidelines of ICD-10-CM with short summary notes with the real examples of ICD-10-CM codebook. Number 1. Locating a code in the ICD-10-CM. You must use both the alphabetic index and the tabular list. So there are two steps you have to follow. The first one is locate the term in the alphabetic index. Second one is verify the code in the tabular list. In the tabular list, read all the instructional notes such as includes, excludes, use additional notes. A dash in the alphabetic index means the code is incomplete and additional characters must be added to the tabular list. But even if no dash appears, you must still check the tabular list for fourth, fifth, and because in the index most of the time you can see the only three codes, but in the tabular list you'll find the fourth, fifth, and sixth characters. Similarly, some codes need the seventh character. Also, the tabular list includes some notes like exclude notes, laterality, code specificity, and clinical instructions. So let's see some example. So example 1, fracture code found in the index but must be completed in the tabular list. Let's see a scenario. Fracture of the shaft of the right ulna, initial encounter. But if you go to the alphabetic index, first you have to go to the fracture, then ulna, then shaft. It will lead you to the code S52.20 dash. You can see this is the real code. It says 52.2 dash. So dash means the code is incomplete. So in this kind of scenario, you have to code up to the level of 7th character. So once you go to the code, you can see S52.201 is unspecified fracture of shaft of right ulna. So in our case, this is right ulna, but initial encounter. So this code is give 6 characters, but the 7th character you have to put for the encounter. So the letter A for initial encounter for close fracture, D for the subsequent encounter, and S for the sequelae. So in this case, it's the initial encounter. So you have to put the letter A. So the correct code will be S52.201A. Let's see another example for the laterality found in the tabular list. So the provided documentation you can see acute otitis media right ear. But when you go to the alphabetic index, you will find otitis media acute. The code will be X66.90. But this is an unspecified code. Once you go to the tabular list, you can see H66.90 is otitis media unspecified ear. But in our case, it is right ear. So right ear is the code is H66.91. That is otitis media unspecific right ear. So the correct code will be H66.91. Let's see another example for tabular list contains code first or use additional code instructions. So let's see a scenario. A provider documentation says diabetic chronic kidney disease stage 4. So when you go to the alphabetic index, first go to the diabetes, then with kidney disease, it will lead you to the code E11.22. So once you go to the E11.22, here is the code description. You can see type 2 diabetes mellitus with diabetic chronic kidney disease. And you can see in the red line, it says use additional code to identify the stage of chronic kidney disease in N18.1 to 18.6. You can see this is stage 4 kidney disease. For to the staging, you have to go to the NCDs code. So once you go to the NCDs, you can see N18.4 is chronic kidney disease stage 4. So our case is stage 4. So the correct coding will be E11.22 and N18.4. Number 2. Level of detail in coding. ICD-10-CM codes must be reported at the highest level of specificity. It means you have to use all the characters the tabular list requires. Use 7 characters when needed. Use laterality such as right, left, or bilateral when provided. And do not stop at a 3 character category if further details are exist. For example, in a condition like fracture of navicular bone of wrist, you can't just code S62.0 because this category requires 7 characters. So the valid code is S62.001A. That is the initial encounter code. So this means unspecified fracture of distal pole of navicular bone of right wrist initial encounter. So you have to code fully. The number 3 codes from A00 to T89.9, Z00 to Z99.8, and U00 to U85. These code ranges cover all diagnoses, signs, symptoms, and reasons for encounters. So use these codes to classify diseases, injuries, poisonings, pregnancy conditions, mental health disorders, symptoms when no diagnosis is known, screening encounters, aftercare, immunization visits, social determinants, and COVID and special pathogens that include in U codes. Number 4, signs and symptoms. Signs and symptoms, that is R codes, may be reported when no definitive diagnosis has been established by the provider. So they are used only when the provider cannot determine the cause of the patient's complaints by the end of the encounter. The R00 to R99 includes most signs and symptoms. So if a definitive diagnosis is confirmed, do not code signs or symptoms that are routinely associated. So in summary, if a diagnosis is known, code the diagnosis. If the diagnosis is unknown, code the symptoms. So let's see some examples. Example 1, symptom reported because no diagnosis was made. So in the documentation says, patient presents with fever and sore throat, rapid step test negative, provider documents viral illness suspected, no definitive diagnosis. So the correct coding will be R50.9, that is for fever unspecified, R0.70, that is pain in the throat. So no definitive diagnosis established. Here the symptoms are coded. The second example, do not code symptoms when diagnosis is confirmed. So in the documentation says, patients presents with fever, cough, shortness of breath, provider diagnosis pneumonia. So here the correct coding will be J18.9, that is for pneumonia with unspecified organism. So here you do not code for cough, fever, or shortness of breath because they are integral part of pneumonia. So no need to code symptoms separately. Example 3, some symptoms cannot be coded even if no diagnosis is found. Some findings such as elevated blood pressure without diagnosis, so you can't code them. Abnormal glucose, so they are symptoms until confirmed as hypertension or diabetes. Number 5, conditions that are an integral part of a disease process. So here do not assign separate code for signs and symptoms that routinely occur with a particular disease. If the ICD-10-CM does not instruct otherwise, assume common symptoms are included in the main diagnosis code. For example, some routine symptoms are, so pneumonia having some routine symptoms like cough, fever, tachypnea. Similarly, migraine having headache and photophobia, congestive heart failure having edema and dyspnea, gastroesophageal reflux disease having heartburn. So those are the integral symptoms. So you no need to code them separately. So let's see some examples. So example of migraine. So in the documentation says, patient has migraine with photophobia and throbbing headache. So here the correct coding will be, you have to code G43.909, that is for migraine unspecified non-intractable. So here you don't need to code for the headache or photophobia codes because those are integral part of the migraine. Similarly, heart failure, documentation says acute congestive heart failure with dyspnea and leg edema. So here you have to code only for the heart failure, that is I50.9, heart failure unspecified or specified type if documented. So here do not code for shortness of breath or edema separately because those are integral part of heart failure. Similarly, gastroenteritis. Here provider documents diarrhea, vomiting due to viral gastritis. The correct coding will be A08.4, that is for viral gastritis. Here do not code for nausea or vomiting or diarrhea. Number 6, conditions that are not integral to disease process. So additional symptoms or signs that are not routinely associated with the disease should be coded when present, because these symptoms contribute additional clinical detail and may affect the severity level, risk adjustment, and medical necessity. So how to identify a non-integral symptom? So ask yourself, is this symptom normally seen with this condition? If no, and the symptom is clinically significant, you have to code it. So let's see some examples. Example 1, chest pain with pneumonia. So the documentation says pneumonia with pleuritic chest pain. So here chest pain is not a routine feature of pneumonia. So correct coding will be, first you have to code for the pneumonia, that is J18.9. Then you have to code for the pleuritic chest pain, that is R07.81, that is pleurodyna, means pleuritic pain. Similarly, another example, diabetes with unrelated symptoms. For example, documentation says type 2 diabetes, patient also has vertigo. So here the vertigo is not integral to diabetes. So correct coding will be, first you have to code for the diabetes, that is E11.9, type 2 diabetes with complication, and R42 for dizziness and giddiness. So in summary, the diagnosis is not known, you have to code the symptom because symptom used for reporting. Symptom is routine part of the disease, no need to code them because that is integral part of the main diagnosis. Symptom is not routine, so you have to code them separately because those are additional clinical details. So the ICD-10-CM instructs to code symptom, you have to code the symptom. So the reason is tabular list overrides the rules. Number 7, multiple coding for a single condition. Some conditions cannot be fully described with a single code. So the ICD-10-CM uses a system of coding instruction to show when 2 or more codes are needed. So we can see in 4 parts. First one is A, etiology manifestation. So code first and use additional code. So there are 2 codes used. First one is for etiology, that is for underlying cause. Then manifestation, that is what the cause leads. For example, diabetes is a cause, retinopathy is a manifestation. So let's see a couple of examples. Anemia due to chronic kidney disease. Here, first you have to code the cause, that is end-stage renal failure in 18.6, that is the etiology, and the manifestation is D63.1, that is anemia in chronic kidney disease as the manifestation. Similarly, anemia due to malignancy, here first you have to code the malignancy, that is C50.212, that is malignant neoplasm of breast, that has the etiology, and the manifestation is D63.0, that is anemia in neoplastic disease as the manifestation. B, use additional code. Here appears under a main condition that needs extra detail. So secondary code is optional only if information is available. For example, urinary tract infection with infectious agents. Here in the instruction, the tabular list you can see N39.0, urinary tract infection, site not specified, but in the red it says use additional code B95 to 97 to identify the infectious agent. So let's see a real example. A patient diagnosed with UTI due to E. coli. So the coding sequence is first we have to code the condition, that is N39.0, that is urinary tract infection, site not specified, and the causative organism B96.20, that is unspecified Escherichia coli as the cause of disease classified elsewhere. C, code first scenario. It appears under the condition that is commonly a result of something else. If the underlying cause is known, sequence is first. For example, as we seen earlier, anemia due to chronic kidney disease. It says N18 advises code first underlying CKD. When you go to the anemia code, that is 63.1, advises code first the CKD. So when here is the real book example, when you go to the code D63.1, that is anemia in chronic kidney disease, it says code first the underlying chronic kidney disease. Similarly, when you go to the underlying kidney disease code, that is N18, you can see code first any associated diabetic chronic kidney disease, hypertensive chronic kidney disease, and use additional code to identify kidney transplant status. So the correct coding sequence will be N18.9 for CKD, stage unspecified, and D69.1 for anemia in CKD. The fourth scenario D, code if applicable any causal condition first. The condition may stand alone, but if a cause is identified, code the cause first. For example, J84.1, that is for pulmonary fibrosis, but in the instruction it says code if applicable any causal condition first. You can see the code notes like this: code first underlying disease such as disorders of iron metabolism. So if provided documents like this, pulmonary fibrosis due to sarcoidosis, first you have to code the causative agent, that is D86.0, that is sarcoidosis of lung, and J84.10, that is for pulmonary fibrosis. Fifth scenario, that is E, multiple codes for sequelae, complication, and obstetrics. So here special rules in their chapters often require multiple codes to reflect the full picture. For example, obstetric code with additional fetal codes. The provided document like this: pregnancy complicated by hypertension affecting fetus. So here you have to code O10.011, that is pre-existing hypertension complicated pregnancy, and O36.4XXO, that is for maternal care for fetus affected by maternal disorder. Number 8, acute and chronic condition. When a condition is documented as both acute and chronic, and both sub-entries exist, then assign both codes. Sequence the acute code first. So acute or subacute always sequence before the chronic. So let's see an example. A patient having acute and chronic sinusitis. The documentation says acute and chronic maxillary sinusitis. So here you have to code the acute condition first. So J01.00, that is for acute sinusitis. and J32.0 for chronic maxillary sinusitis. Number 9, combination codes. Combination code is a single ICD-10-CM code that classifies two diagnoses, or a diagnosis plus manifestation or a diagnosis with complication. This allows for more concise reporting and prevents the need for unnecessary multiple coding. So the combination codes are found by searching the subterms in the alphabetic index, where you have to checking the specific wording, inclusion terms, and instructions in the tabular list. Example of clues like with, and, or associated with. The terms that describe both disease and complication in one code are these: with, and associated with. So here some key roots are available. When it fully describes all documented conditions, use only the common combination code. If the combination code already includes all elements, that is diagnosis plus manifestation or complication, do not assign separate codes. If the combination code lacks necessary specificity about the manifestation or complication, then you have to use the additional codes. So you have to be thorough with this. So let's see some examples. Example 1, type 2 diabetes with polyneuropathy. So here the correct coding will be E11.42. So E11.42 is type 2 diabetes mellitus with diabetic polyneuropathy. So this one code includes the both diagnosis and manifestation. Similarly, let's see another example, gastric ulcer with hemorrhage. The documentation says acute gastric ulcer with bleeding. So when you go to the code K25.0, that is acute gastric ulcer with hemorrhage. So the single code having the diagnosis and the manifestation. So there's no need to add the separate bleeding code here. Let's see another example, COPD with acute exacerbation. So in the documentation says chronic obstructive pulmonary disease with acute exacerbation. So this can be coded with a single code, that is J44.1 says chronic obstructive pulmonary disease with acute exacerbation. Similarly, asthma with status asthmaticus. So the documentation says moderate persistent asthma with status asthmaticus. So it is exactly represented in the code J45.42, that is moderate persistent asthma with status asthmaticus. So one code captures both the condition and the complication. Number 10, sequelae, that is late effects. A sequelae is a residual effect remaining after the acute phase of an illness or injury has ended. For example, paralysis after a stroke, scar from a burn, deviated septum from old nasal fracture, chronic pain after trauma, infertility from past infection. So these sequelae do not have time limit. It may occur weeks later, months later, or years later. So the coding rule for this sequelae, first, you have to code the condition or nature of the sequelae, that is the current problem. Second, code the sequelae code, that is the original code, usually ending in S. So let's see some examples. Scar from an old burn. So the documentation says hypertrophic scar of the left hand due to old third degree burn. So first you have to code for the hypertrophic scar, then code for the third degree burn. So the correct coding will be L91.0, that is hypertrophic scar, T23.302S, that is burn left hand third degree sequelae. So correct S is for sequelae. Example 2, chronic pain after prior trauma. The documentation says chronic right shoulder pain due to previous fracture. So here the current condition is pain. You have to code the pain first, then the previous condition, that is previous fracture. So the correct coding will be G89.21, that is for chronic pain due to trauma, S42.201S, that is fracture of right humerus unspecified as a sequelae. So let's see another example, infertility from past TB. So the documentation says female infertility due to old tuberculosis infection. So first we have to code for the female infertility, then code for the previous condition tuberculosis. So the correct coding will be N97.1, that is female infertility of tubal origin, B90.09, that is for sequelae of tuberculosis. There are some exceptions. So some sequelae codes already included in the manifestation, so only one code is needed. For example, hemiplegia from previous stroke. So the documentation says left-sided hemiplegia due to old ischemic stroke. In this scenario, you need to code only one code, that is I69.354. The code itself says left hemiplegia following cerebral infarction. So the sequelae includes both the residual and cause. So only one code is needed. So you can see the real code here. It says hemiplegia and hemiparesis following cerebral infarction. So it including the current and the late effects both in one code. Number 11, impending or threatened conditions. Impending conditions, a condition expected to develop soon. Threatened condition means a condition at high risk of occurring. So the coding rules are, if the condition occurred, code it as confirmed. For example, impending MI that becomes confirmed MI, code myocardial infarction. If it did not occur, check if impending or threaten appears in the index. If the alphabetic index lists a specific code, assign that code. If the index does not list a code, do not code the impending condition, then code the underlying presenting symptoms or condition instead. So if you may get confused, but when you do the example, you will understand it clearly. So let's see some example. First one, threatened preterm labor. So go to the alphabetic index. So there's entry exists for threatened labor. The documentation says threatened preterm labor at 32 weeks. So the correct coding will be O47.03. That is false labor before 37 completed weeks. So when you go to the tabular list, O47 is for forced labor that include Braxton Hicks contractions and threatened labor. So it's include the threatened labor. So the O47.0 is false labor before 37 completed weeks of gestation. Let's see another example, impending myocardial infarction. So the documentation says patient admitted with chest pain provided documents impending MI, but the MI did not occur. So in the index, there's no entry for impending myocardial infarction. In that case, you have to code for the symptoms. So R07.9 for chest pain. If it is said as angina, you can code I, but you can't code, do not code for this MI because it is not occur. Number 12, reporting the same diagnosis code more than once. A single ICD-10-CM code may be reported only once per encounter. This applies even if the same condition occurs in multiple locations, for example, both legs, or the condition appears twice in the same encounter, or the documentation repeats the diagnosis multiple times. So the special note for this bilateral conditions, when laterality specific codes do not exist and both sides are affected, report the code only once. Compared to this CPT coding, this ICD-10 coding is slightly different here because ICD-10 codes represent conditions, not the number of sites. So multiple reporting inflates diagnosis count and violates the coding rules. So in ICD-10-CM, you have to code a condition only once per encounter. So let's see some example. Bilateral condition with no laterality options. So the diagnosis says tinea corporis on both arms. So you have to code B35.4, that is for tinea corporis. So here the condition is bilateral. There's no left-right code. So assign B35.4 only once. Let's see another example. Same code for different sides. So diagnosis says multiple skin cysts on scalp and back. So you have to code L72.0 for this epidermal cyst. Even though there are multiple cysts, report only once. Example 3. Two conditions classified to same ICD-10-CM code. For example, diagnosis says acute pharyngitis and acute nasopharyngitis. So both are mapped into the code J02.9. You can see this code description. So it includes the acute pharyngitis unspecified. So you have to code J02.9 only once. Number 13, laterality. Many ICD-10-CM codes specify right, left, bilateral, or unspecified. So if a bilateral code is exist and both sides are affected, use the bilateral code. If no bilateral code is exist, assign separate right and left codes. If the laterality is not documented, use the unspecified side code. But this should be rare and coder should attempt clarification unless impossible. When bilateral condition treated in separate encounters, first encounter use the bilateral code. Second encounter, after one side has improved or resolved, use the unilateral code for the remaining side. So this may be used in cataract surgery time. So we'll see in the examples later. So the condition is unsolved in the first side, continue using the bilateral code. And the laterality may be taken from other clinicians, example, nurses' notes. But conflicting documentation requires provide a query. So let's see some examples. First example for available bilateral code, that is diagnosis is bilateral acute otitis media. So when you see the code H66.93, otitis media unspecified bilateral. So it says, so this one code itself says bilateral. So you can use this code. Example 2, no bilateral code available. For example, bilateral knee pain. So here you can see the code M25.5614, pain in right knee. M25.562 for pain in left knee. So there's no bilateral code. So you had to use both code. So you had to assign the both codes. Example 3, first and second encounter scenario. Let's see a patient with bilateral cataract. So the first encounter, you have to diagnose with the bilateral cataract code. So in the first encounter, she underwent right eye surgery. So in the second encounter, you had to code only for the left cataract because right cataract is already resolved. So like that, with the differential encounter, you have to change the diagnosis. Number 14, documentation by clinicians other than the patient's provider. ICD-10-CM code assignment is normally based only on provider's diagnosis, but certain supporting details may come from other clinicians. The details can come from non-providers are BMI, pressure ulcer stages, pressure ulcer depth, non-pressure ulcer depth, coma scale, NIH stroke scale, laterality, blood alcohol level, social determinants of health, under immunization status. But the actual diagnosis must come from the provider. So we will understand when you do the examples. So let's see. A nurse documents patient's obese BMI 38. So here the diagnosing obesity must be done by the provider before BMI code can be assigned. So if the documentation conflicts, query the provider. Codes from this list are always secondary diagnosis, not principal. So let's see example 1. BMI documented by dietitian, but the provider says patient diagnosed with obesity. The dietitian note says BMI 41.3. So here the provider diagnosed obesity. So you can quote the obesity code, that is E66.9. So that's the primary diagnosis. So when you diagnose the obesity, then you can use the dietitian's note for BMI. So you can use the code Z68.41 for BMI 40 to 44.9. So BMI comes from dietitian, but the primary diagnosis is done by the provider, that is the physician or the medical consultant. So example 2, pressure ulcer stage documented by nurse. So provider documents, provider is the treating physician, diagnosed as a pressure ulcer from sacrum, and the nurse's note says stage 4 pressure ulcer. So you have to quote the provider's note as the diagnosis, then you can use the nurse's note for the staging. So the correct code is L89.154, that is pressure ulcer sacral region stage 4. So the stage comes from the nurse's documentation. So example 3, social determinants of health. So social worker notes as patient is homeless. So in this scenario, Z59.00 for homelessness unspecified. So here diagnosis does not require physician confirmation because social determinants of health can come from other clinicians as well. Example 4, coma scale documented by emergency personnel. So the provider documents traumatic brain injury, but EMT notes as GCS 6 at scene. So you can quote S06.9X1A, that for unspecified intracranial injury with loss of consciousness. And you can use the coma scale because already diagnosis is given. So R40.2431 is coma scale GCS 6. So it's come from EMT documentation. Number 15, syndromes. Syndrome often include multiple interrelated signs, symptoms, and manifestations. Always follow alphabetic index guidance first. If the index lists a specific code for the syndrome, use that code. If no specific code is listed, assign codes for each documented manifestation of the syndrome. Additional manifestation codes may be reported for features not integral to the symptom. So let's see some example. Example 1, Down syndrome. So when you go to the alphabetic index, it shows Down syndrome Q90.0. So when provider documents as like this, Down syndrome, congenital heart defect. So go to the tabular list, you can see Q90.9, that is Down syndrome unspecified. And for congenital malformation of heart, that is Q24.9. So here the additional manifestation not inherent to the genetic code are separately reportable. So you have to report these codes separately. Example 2, Marfan syndrome. So when you go to the alphabetic index, it lists Marfan as Q87.4. So the provider also documents bilateral lens dislocation. So in this scenario, first you have to code for Marfan syndrome, that is Q87.40, that is Marfan syndrome unspecified. And also bilateral lens dislocation, you have to code H27.03, that is bilateral lens dislocation. There are manifestations not included in the base code, so you have to code those separately. Example 3, syndrome not listed in index. For example, provider documents autobrevary syndrome is a rare condition, so that is not in the index entry. So that the clinical manifestations of autobrevary syndrome listed in the document as recurrent intoxication, mild hepatic dysfunction. So in that scenario, you have to code for the symptoms. So here F10.12984 alcohol abuse with intoxication and K76.894 for other specified liver disease. So this syndrome is not coded directly, so the manifestations are coded. Number 16, Documentation of complications of care. A condition can be coded as a complication of care only when there is a documented cause and effect relationship. So the provider must indicate that the condition is due to result of or associated with the procedure or care. Or number two, the condition is clinically significant, mean it altering the course of treatment, requires additional care, or impacts recovery. Number three, provider does not need to explicitly use the word complication. The relationship may be implied in the documentation. The coder should query the provider when unclear. Number four, not only every post-procedure occurrence is a complication. Example, expected pain after surgery is not coded as a complication unless excessive or abnormal. So let's see some examples. Example number one, intraoperative hemorrhage. So the operative note says excessive bleeding noted during spleen procedure requiring additional sutures. So in that case, you can use the coding D78.01, that is intraoperative hemorrhage of spleen, appropriate procedure code. Even though the term complication wasn't used, the documentation supports it. Example 2, infection after device placement. Provider document says patient presents with cellulitis of pacemaker pocket due to the device. So coding you can use T82.7, that is infection and inflammatory reaction due to other cardiac and vascular devices, implants and grafts. So correct coding will be T82.7XXA, that is infection and inflammatory reaction due to cardiac device, and L03.313, that is cellulitis of chest wall. Example 3, not a complication. Example, provider document says mild post-operative nausea expected, no intervention needed. So in that scenario, not coded as a complication, only code if it is treated clinically or clinically significant. Example 4, query needed. Provider writes bleeding from surgical site, so there's no documentation linking it to the procedure. In that scenario, must query the provider to confirm whether it is a complication. Number 17, borderline diagnosis. Borderline diagnoses are coded as confirmed unless ICD-10-CM provides a specific borderline option. Borderline conditions are not uncertain diagnoses. Applies to inpatient and outpatient encounters. If unclear, query the provider. Let's see some example. Example 1, borderline diabetes. So ICD-10-CM has a specific entry R73.03 pre-diabetes. So if the provider documents borderline diabetes, you can code R73.03 as pre-diabetes. Example 2, borderline personality disorder. So ICD-10-CM has a specific entry F60.3, that is borderline personality disorder. So documented as borderline personality tendencies. So code F60.3 because the term matches in the index entry. Example 3, borderline hypertension. No specific borderline code exists. So provider writes borderline hypertension, code as confirmed hypertension, that is I10, essential hypertension, unless provider clarifies otherwise. Number 18, use of sign, symptoms or unspecified codes. Sign or symptom codes are acceptable when a definitive diagnosis is not established by the end of the encounter, multiple potential diagnoses exist, or workup is incomplete. Unspecified codes are appropriate when documentation cannot be more specific. The provider knows the general condition but not the type. So never choose a more specific code unless supported by the documentation, and do not order extra tests just to get the specific code. So the code must be match existing documentation, not force extra diagnostics. Example 1, symptom code when diagnosis is not confirmed. A patient presents with fever, cough, chest discomfort, X-ray negative for pneumonia. In that scenario, you have to code for the symptoms. For example, R05.9 for cough, R50.09 for fever, R07.89 for chest discomfort. So there's no definitive diagnosis. You have to use the symptom. On the other hand, the provider document as pneumonia, you have to use J18.9, that is pneumonia, unspecified organism. So this is the appropriate code. Example 3, unspecified abdominal pain. So provider cannot determine the exact cause. So you have to use the code R10.9, that is unspecified abdominal pain. Example 4, definitive diagnosis established. Do not use the symptoms. For example, provider documents migraine headache causing nausea and vomiting. In that scenario, you had used the code G43.9, that is migraine unspecified. Do not code for nausea or vomiting separately unless the documentation shows it requires separate treatment, because nausea and vomiting are the symptoms of migraine. 19A, use of external cause of morbidity code. External cause codes describe how an injury or condition happened, including cause. Example, hurricane, building collapse, or falling debris. Intent, unintentional or intentional. Place of occurrence, activity at the time of event. Status, that is civilian or military. So external cause codes are supplemental, never sequenced as the principal diagnosis. The injury or condition code is always assigned first. Assign external cause codes only when injuries, poisonings, or adverse effects are related to events like hurricane are present. External cause codes should not be assigned for chronic condition unrelated to storm. Example, diabetes checkup, encounters with no injury or adverse effect. External cause codes may be assigned in any healthcare settings, including hospitals, clinics, shelters, mobile units, and temporary care tents. So let's see some example. Laceration from flying debris during hurricane. So the documentation says like this: patient struck by flying metal during hurricane, deep laceration to forearm. So codes are, you have to code the primary cause for the injury, that is S51.811A, that is laceration of right forearm. Then other cause codes SX37.0XXA for hurricane initial encounter, W21.1XXA for struck by thrown or projected object, Y92.019 for place home, Y93.K9 for activity other specified activity, Y99.8 for civilian activity. So all these codes are describing this event. Example 2, asthma exacerbation due to mold exposure. So here there's no injury. So let's see a documentation like this. Wheezing worsened after staying in deep damp shelter, no physical injury. So no external cause codes assigned because there's no injury, poisoning, or adverse effect. So you code only for J45.901, that is asthma exacerbation. Example 3, chainsaw injury while cleaning debris after hurricane. So the documentation says laceration of thigh while using chainsaw to clear fallen trees after hurricane. So the codes include the primary code for the injury, that is S71.111A, that is laceration of right thigh, X37.0XXA for hurricane, W29.1XXA for contact chainsaw, Y93.H2 for activity cleanup, Y99.8 for civilian status. 19B, sequencing of external cause of morbidity codes. Cataclysmic event codes takes priority over other external cause codes except child abuse, adult abuse, terrorism. Therefore, for hurricane related injuries, X37.0, that is hurricane, is sequenced as the first external cause code. So in case of multiple external cause codes may be required, assign all that apply, but hurricane related decision rules X37.0, that is injuries directly due to hurricane, including levee break caused by hurricane. X38 code series for flooding resulting directly from the storm. X36.0, that is collapse of dam or man-made structure due to earth movement, not due to hurricane. So do not use hurricane related collapses with this X36. So let's see some example. Example 1, building collapse during hurricane. So patient trapped under collapsed apartment building during hurricane sustained multiple fractures. So here you have to code first the injuries, that is X52.501A for fracture of radius and S72.001A for hip fracture if these are occurs. When you code for external cause codes, first we have to code the hurricane first, that is X37.0XXA for the hurricane and W20.8XXA for stuck by collapsing building. So then add place activity status code as documented. Example 2, injury from levee break caused by hurricane. So here you have to use X37.0, not X36, because this building break due to hurricane, not separate. So let's see the documentation. The patient injured after being swept away when levee broke during hurricane. So here the code is T75 point drowning or near drowning if it is documented. Then the external cause codes X37.0XXA for hurricane, X38.XXA for flood. if directly caused by storm. Both can be used and hurricane goes first. Example 3, flooding unrelated to hurricane. So documentation says injury from river flood caused by heavy rain. This is not due to hurricane. So you had used the appropriate code for the injury, then code for the external cause, that is X38 for flood. Here do not use X37, that is related to hurricane related flood. 19C, other external cause coding issues. If injury is not caused by hurricane, code only actual cause. Example, motor vehicle accident. If uncertain whether hurricane is contributed, assume it did. Continue to assign hurricane code for each encounter related to that injury. For example, evacuee in MVC, not hurricane related. So documentation says evacuee injured in motor vehicle accident while traveling to shelter. First we have to go to the injury code, then the external code. So injury code is X16.1XXA for next train. The external cause code is V43.52XA, that is car occupant injured in MVC. Here do not assign X37 because injury is not caused by hurricane. Example 2, cause of injury not clear. So documentation says patient with foot fracture during evacuation, unclear if due to storm impact. So if in that scenario, you have to assume that hurricane is related. So you have to quote the injury first, that is S92.351A, that is for fracture of foot, and X37.0XXA for hurricane. So and then add place activity codes as documented. Example 3, exposure injuries after hurricane. So document says hypothermia after wading through flooded streets post hurricane. So here you have to quote first the hypothermia, that is T68.XXA for hypothermia, and X37.0XXA for hurricane, and X31.XXA for exposure to excessive natural cold. 19D, use of Z codes in hurricane related encounters. Z codes help report social circumstances, living conditions, dependence on equipment, utility failure issues, healthcare access barriers. Z codes can be principal, that is if reason for the encounter, or secondary if supporting information. So assign as many as Z codes as necessary to fully describe the encounter. So some common Z codes in disaster aftermath are Z59.0 for homelessness, 59.1 for inadequate housing, 59.5 for extreme poverty, 75.1 for awaiting admission to facilities, 75.3 for unavailability or inaccessibility of healthcare facilities, 75.4 unavailability of helping agencies, 76.2 for supervision of healthy infant or child, 99.12 for respirator dependent during power failure. So let's see some example. Homelessness after hurricane. So documentation says patient process for medication refill, home destroyed by hurricane. So in that scenario, first you have to quote Z76.0 for medication refill, Z59.0 for homelessness, hurricane. Here, if any injury or condition is related, otherwise you have to omit this. Example 2, ventilator dependent during power failure. So documentation says patient on home ventilator presents because power outages prevent ventilator use. So here you have to quote Z99.12, that is ventilator dependence during power failure, Z75.34 inaccessibility of healthcare facility if applicable. So here no injuries, so no external cause codes. Example 3, child seen in shelter for routine check. So documentation says healthy child seen for routine evaluation displaced due to hurricane. So here the codes are Z76.2 for encounter for supervision of healthy infant or child, Z59.1 for inadequate housing. So here external cause codes not applicable because there's no injury. Example 4, patient awaiting transfer to appropriate facility. So the documentation says hospital at capacity due to storm damage, patient boarded in hallway awaiting transfer. So here the codes are Z75.1, that is person awaiting admission to adequate facility, and other medical diagnosis is applicable, but here no injuries, so no external cause code are reported. So this is the summary and detailed explanation of ICD-10-CM General Coding Guidelines from 1 to 19. So if you have any questions, please leave in the comment section.
So if you are preparing for the AAPC CPC examination, my channel will help you to solve the problems you are facing in your examination preparation. So please subscribe my channel. And if you have any doubts or any questions, you can put in the comment section, or else you can email me, or you can WhatsApp me to the email and the WhatsApp number displayed here. So please subscribe my channel and stay with me. Thank you.